raises, we are bringing more people into our healthcare system, but as we heard from the prior panel that I want to say I just thought was excellent, incredibly thoughtful, really great discussion. We have a lot of work to do to improve the healthcare system that we have, and maybe it's something we can talk a little bit more about as some of the initiatives we have within HHS to continue improving the quality of care, the value of care that we deliver, and really the outcomes that we get for what we spend. And then the third thing we were talking a little bit about before the panel started that I think is an incredibly important challenge, and I'm very sort of buoyed by what I see when I'm out in the field. I spend about half my time actually traveling throughout the region, on the ground, meeting with all kinds of stakeholders within the field of health and human services, including consumers themselves, patients. And there's new work, there's new things happening, there's new energy around really thinking about the intersection between what's been traditionally thought of as public health or community health, about what the underlying drivers are to create a healthier population, and what's happening in the medical care and healthcare arena. At least when I started my career working in a county health system, those two parts of the health system did not speak to each other. They each kind of did their own thing and knew what they were doing, even though both are aiming toward the same place, which is better health for individuals, families, and communities. And I see more happening in that arena. I think we have a lot more work to do, but I think it's incredibly important that we be able to simultaneously work on improving the healthcare system that people are in from a medical care, healthcare standpoint, and really think about how do we work on improving the underlying causes that cause ill health, but also really think about it from a community and public health perspective. So those are all big challenges. I don't think any of them are easy though.
So following on from that, when you think about those current uninsured, people who are still not accessing the system, what do you think the biggest barriers for them are?
Yeah, that's a really good question. This year I spent quite a bit of time, particularly in the state of Arizona, and the reason for that is in Region 9, Arizona uses the federal government's exchange in terms of the structure of the Affordable Care Act and the exchanges. And this is for the group of people between about 138 to 400% of poverty who are able to access financial assistance to pay for their health coverage, to pay for premiums if they purchase their coverage through the exchange. California runs its own, it's called Cover California, you're probably familiar with it. Arizona uses the federal exchange, so I spend a little bit more time there during open enrollment, and I actually go to many open enrollment events and talk to both the navigators and assisters who help people sign up for health insurance, but also to individuals and families who are coming to sign up. And I think it's a couple of things. One is, this is a place where I think we have more work to do at HHS and with our many partners. There are still a lot of people who don't actually know what's available to them. We have not, I know we talk about it a lot, and in our world, we feel like this is what we talk about all the time, but there are still a lot of folks who are not aware of what their options are in terms of getting health insurance. The other thing we absolutely know is that people are not aware of the financial assistance that's available to them. They assume, because we talk about the high cost of healthcare, and we can talk a little bit more about that. I think we've made some progress. We still have more work to do. But people assume that it's not affordable, and so they don't even consider the possibility. We've absolutely seen that as we talk to individuals and families. They often assume that, and we really encourage people to just go find out. One of the things we added this year to the federal healthcare.gov website for people signing up for the exchange was something that was called a total cost calculator. And it was very interesting because I got a lot of feedback that was sort of people's favorite new thing that we did this year, because what it lets you do, and you can actually do this yourself, I did it myself during open enrollment, you can go in and I think you answer maybe 6 questions pretty quickly, and it will give you a quick guesstimate of what the cost of purchasing health insurance will be, but not just for your premiums, but for looking at your deductibles, your co-pays, trying to give people some information about what will be the total cost of purchasing insurance, including if they're eligible for tax credits or financial assistance. So I think we still have work to do getting the information out to people. I think, of course, we're challenged with the young invincibles. That is still a hard population to reach in terms of thinking about sort of the cost benefit of having health insurance and whether it's a value to them. And then I do think there's a group that is just not interested in purchasing coverage that is connected to government still. That is something that I hear when I'm out and about, and that's still a challenge, but I think we have more education opportunity to do. The other thing that we hear a lot is many of these decisions are made by word of mouth. When I ask people how they heard about, say, an enrollment event that we do a lot, say, at schools, places where families would come to regularly, they usually hear it from a friend or a neighbor or a family member. Because of the demographics of Arizona, Spanish language radio is probably one of the biggest places that people hear about it. So we really have to think about how to embed thinking about health insurance into what people do all the time. So one of the things we did this year was try to have information more, say, at grocery stores or at general places where people go all the time. Schools are actually a really important connection point for people learning about health insurance. So I think there's barriers, and then I think there's still folks, as you pointed out, who are over 400% of poverty and are still challenged in terms of affordability.
As far as, if we can just talk about California just for a minute.
Sure.
So Covered California has been sort of lauded as one of the more successful exchanges, except the narrow networks are really problematic, I think, in certain parts of the state. And recently, Peter Lee, the director of Covered California, wrote an op-ed where he basically justified the insurance consolidation as a good thing. But wouldn't that further narrow the networks, in your opinion? And how is your... He was basically making the case that mergers were actually better, and I just didn't see how the head of Covered California could be making that.
I try to read actually what Peter writes, and I have to say I didn't see that particular op-ed that he wrote that he was making. I mean, I think on the issue of narrow networks, we have a regulatory framework. So the way the regulatory framework works from an ACA perspective is that for the ACA plans at the federal level, we lay out what sort of the minimum standards are in terms of what network adequacy is and what basic access standards are, both for the ACA, for Medicaid, Medi-Cal here in California. And then those are enforced at the state level in departments of insurance. That's sort of how the regulatory structure works, as you know from having worked with Dave Jones and the insurance department here in California. And I think that there is work to do on transparency of those networks so that people actually know when they are purchasing a plan through the exchanges, who's actually in the network. This is a very real issue and actually something that the Center for Medicare and Medicaid Services, which is part of HHS, you heard it mentioned in the prior presentation, is actually really working on. How do you get real-time, ongoing, up-to-date, accurate information about what are the doctors, the providers, the hospitals in a network so that when a consumer is making a choice, if they are looking at a plan within their network, they understand what they're buying. And I think consumer engagement around this is very important because people, I think, have trade-offs to make in terms of what their healthcare needs, what their family's budget issues are. They need to have sort of full information around that. And I think that's an area where we've actually put in place some additional regulatory requirements at the federal level, actually within the last year, and those are still being implemented. But I think there is some good work happening to make sure that a consumer actually knows what that is. But to me, that's a really important piece. If somebody wants to choose a narrow network, because for them maybe it works down the price side for them, they need to know, if the doctor they want is in it or who's part of that network. So I think there's still work to do on the regulatory side to even enforce and sort of make more real at a consumer level the regulation that we have around the issue of network adequacy. At least when I'm talking to consumers, the issue around network that comes up the most that I hear, and I don't know if this is what you heard as a sort of a practicing physician, is they want, in many cases, particularly if they have an ongoing chronic disease or other issues, they want to be able to keep their own primary care doctor, or sometimes a specialist that maybe they see very regularly. So I don't hear, I want to have, this is just at least maybe the people I've talked to, I don't hear, I want to make sure I have a choice of, X number of physicians. I want to know that if there's a particular physician, I want to have it there actually in my network. And so that's what I hear more in terms of the network adequacy sort of desire from a consumer perspective, which is why I think it's so important, and I think there is some good work happening. On healthcare.gov this year, you could actually search each plan, see if your doctor was in it, which was not a feature we had had in the prior years. I think there's continuing work to do to make sure that that information is accurate and up to date, but I think that that's a really important piece for consumers.
But about consolidation on the provider side, or the large pharmaceuticals, biotech companies, increasingly we're seeing these things get coming together and having a great deal more influence on what is provided to a patient. And we had this dream of more patient voice, but do you think that's a reality?
There's a couple of questions in there. So let me try to maybe break it down to a few things. So I think in terms of the consolidation piece, so there's kind of two levels within the federal government in which that would get looked at. So, on the insurer side, it's actually the Department of Justice that looks at issues, antitrust, et cetera. That lens of how that sort of fits in terms of the business aspect of that doesn't happen within HHS. It happens within Justice and happens within the FTC, as you know, for the pharmaceutical side. So there's sort of that layer of looking at what's happening in terms of market consolidation and what the legal aspects are around that happens in a separate part of the federal government than the part that sort of is regulating the content aspect. So I think structurally it separates those pieces. It's sort of the framework that we currently have. I think from an HHS perspective, we obviously want to see a robust, competitive marketplace within healthcare, particularly when we think about federal exchange, and the ability to have that price competition within that to try to continue to work on affordability. I think we've made some progress on affordability, but we clearly have more work to do with the cost of coverage itself, the underlying cost of healthcare that drives that price of insurance as well. And one of the ways we look at that, and Secretary Burwell, my boss, the Secretary of HHS, is very metrics driven. And one of the ways we look at that is how many consumers in the exchange have a choice of at least 3 different health plans. As a way to sort of see, do people actually, and is there that competition happening, or what is the impact of the different consolidations that we see? And at least for the 2016 open enrollment period, 9 out of 10 consumers in the exchange had a choice of at least 3 plans. So it's not the only metric we're looking at, but it's at least one that there is still choice happening. But yes, we want to continue to see a competitive, vibrant marketplace in terms of that, and so that's something that we're continuing to watch and to look at. I think in terms of the patient voice, this was touched upon actually in the earlier panel. So I guess I see it as sort of 2 of the positive signs, I would say, that I see. So one is we actually have seen a more engaged and knowledgeable consumer when we have looked at what's happening in the exchanges. Both sort of from a number standpoint, but also, at least from my perspective, anecdotally, being out in the field talking to folks. So, for example, this year, we had many more people who had signed up for coverage through the federal exchange, who signed up in the very first part of open enrollment this year, compared to the prior years where we saw people wait till sort of the very end of the open enrollment period. Because I think generally all of us human beings tend to be procrastinators on these kinds of things. They're complicated, sometimes they're daunting. But this year we saw 7 out of 10 returning consumers actually proactively shop and look at what their choices were for a health plan, and not to, the system will actually auto re-enroll existing customers if they don't do that. But we saw many more this year actually come, look at what their choices were, and proactively choose a plan, not just wait to be auto re-enrolled. And so I think one of the messages we're taking from that is we are seeing actually a more engaged consumer who's thinking about what plan works for me, what plan works for my family in terms of price, in terms of network, in terms of what my healthcare needs are. And I see that as a very sort of positive sign. The other thing that we heard, and I haven't seen any data on this yet, it's more when I'm talking to a lot of assisters, navigators, people who help people sign up for coverage, and some consumers themselves, is last year for me, so it was the second enrollment period, so in sort of 2014, 2015 when I first started in this job, almost every enrollment event I went to, what I would hear is that people were almost only focused on the monthly premium. And that this is a very price-sensitive population, right? Between 138 and 400% of poverty, we know that actually price is the biggest determinant, is when people choose which health plan they choose in the exchange on. It is definitely driven by price. And people were looking primarily at the premium only. And we know though, right, the cost of insurance, as some of your slides show, includes the deductible, includes co-pays, includes other cost sharing, and people were not necessarily taking that into account. And part of that is just the complexity, right? Health insurance is complex, even for people who work in the healthcare field, to make sure that you're choosing a plan that makes sense for you. And one of the things I actually heard quite a bit this year is that, at least anecdotally, some consumers were coming in and saying, I do not want the plan I had last year. I realized I did not make a good choice. You know, maybe it had too high of a deductible and I have diabetes and I go in to see my doctor regularly. I want to figure out a plan that makes more sense for me, and a willingness to pay a little bit more maybe in a monthly premium to have a lower deductible that would make sense for them. Or some of the plans now in their plan design are offering a certain number of free primary care, not free, I shouldn't say that, primary care visits before you have to pay your deductible, and consumers want to know about those kinds of plans. I think we're seeing a more informed, educated consumer. Now that's not everybody. I'll tell you sort of I know this was a heartbreaking story for this navigator I was talking to who was helping somebody sign up for health insurance. They were helping a woman at an enrollment event actually at a school, who, navigators, by the way, and assisters, people who help people sign up for health insurance, are not allowed to steer them to particular plans in federal exchange. They can provide them information, they can answer all their questions, but they can't, if the consumer says to them, well, what plan do you think I should get? They're not allowed to steer people to any particular plan, because they're supposed to be unbiased, and we want them to do that, right? Provide people with information. But it was clear that this consumer had some health issues and was probably going to be getting, health care on a regular basis, but was adamant that she only wanted the lowest premium plan, even though it had a higher deductible and some higher co-insurance. And this navigator was telling me she was doing everything she could to ask this person every question she could imagine to help this person think through the implications of that. But in the end, this consumer just made a decision that for her, at that moment in time, the lowest premium plan was what she was going to go for. The good news is she signed up, so at least, if something really catastrophic happens, she has the protection of that, which is incredibly important, we find, for people's peace of mind and thinking about their finances. But I think we all need sometimes experience or need to have that to think through what plan is going to work best for us. And so I think there's more work to do on that in terms of sort of patient-centric. The other thing I do is positive movement, I think, in the delivery of healthcare, about really making patient-centered care real. I mean, there's been a lot of talk about patient-centered care for, how long would you say? Well, at least 10 years, maybe going a little longer than that. But I think it's been more real in some places than others. And I do think there is more emphasis, more effort on that. For example, I'm very pleased to hear about, there are some health systems now who, when they're doing a quality improvement project, only consider it a valid quality improvement project if there's a patient or family member on the team. There are places that are doing that now. There are health systems that are doing that. So I do think there is much more focus on bringing that true patient-centeredness to care, but we have a long way to go to think about that. And that's actually a mantra people should know of Secretary Orwell, which is what are we doing to put the patient at the center of their care? How are we doing that? So I think HHS is very committed to that, and you see that probably in a lot of our work through the Center for Medicare and Medicaid Innovation, some of the work we're doing on delivery system reform.
So one of the things I know the ACA did well was it raised sort of the basic minimum standards of coverage.
Yeah.
So I think that is really a positive, but on the other side, there were certain people in California that complained because their premiums went up rightfully because they were paying for better coverage.
Yeah.
But on the, I would ask about the bronze plans, because in some respect, from a physician standpoint, it's hard to say that's really coverage. Because I find most of the people that sign up for that, as you mentioned, are buying it because it's the cheapest that they can afford. And then when they get sick, they realize they can't afford to go see the doctor because of the high deductibles and copays. So is that really insurance, or is that, should that be even offered on the exchange? I mean,
yeah, I mean, I think at this point in time, it is the structure, right? So, I mean, it is the structure that there has to be a bronze plan offered. It's one of the metal tier offerings, and the different plans, for those of you who may not be familiar with that, they cover different levels of actuarial value, and the bronze is that covers the lowest actuarial value of the care that's, anticipated to be delivered. And typically, those are the cheapest on a monthly premium, but they often have higher deductibles than the other plans. So, I think for certain consumers, that is the plan that they want, and that is an offering for them. And although I understand completely the point that some of those folks have a very hard time, if it's even possible for them to afford their deductible, at least it is providing sort of that catastrophic coverage if something else does happen. They have much higher medical bills than what their deductible covers. To me, the work we have to do is this work that I was talking about, which is really supporting consumers in being educated, informed, and engaged about their choices. Because if it's not a good choice for them, I guess the reflection I would take back is, well then, how do we need to provide and share the information so that they can make a choice that is a better choice for them, because it is their choice around what plan that they are choosing. And I think there are some ways to do that. So for example, one of the places where Covered California really is a leader is it has standardized its benefit design in the metal tiers for the gold, silver, and bronze plans, so that consumers can more easily compare across insurers and across metal tiers what's covered and what the cost is going to be. In the federal exchange, that is a place where we've not had that. We have not had any standard benefit design. So for example, somebody in Phoenix, Arizona, often will have over 100 plans to choose from. And it's not always easy to compare. It can be apples to oranges in terms of the comparison. But we are actually moving and have some concepts we'll be introducing for next year that's come out in regulation already around sort of the beginnings of more standard benefit design on an optional basis for insurers in the federal exchange. So to me, at the heart of it is helping consumers get into a plan that's right for them from a healthcare perspective and from a sort of cost and family budget perspective. And so to the degree there are people still who are sort of in a wrong plan that doesn't make sense to them, we just have more work to do there.
Because it just seems counterintuitive. On one hand, you increase benefits, but then you allow people to buy a plan that really it's too expensive for them to ever really utilize. Because the average person who probably buys a bronze plan doesn't have 5,000 or 6,500 sitting around to cover an illness. So that's always...
Yeah, and that's where I think as I mentioned, the most positive feedback I got about sort of what changes we made from the last open enrollment to this open enrollment that just closed recently was this total cost estimator. Because it really helps families and individuals think about and see on a screen very quickly after just a few questions what is likely to be my total annual or monthly cost of care, and it factors in that deductible. And I think that is just a piece where, the complexity maybe of health insurance makes it harder to do, but just the fact that it's more complex, I don't consider that an excuse. We just have to do that work then. And I think we are seeing more engaged consumers, but I think we have more work to do there. And I think people will continue to use that tool.
So do you think there's value, in some providers to work better together to actually help people understand and afford preventative care as opposed to reactionary care, so that people they know what good preventative care for their family looks like, what it's going to cost up front, what the coverage means for that, and feel comfortable actually engaging in that preventative care and keeping out of the hospitals and keeping out of the chronic conditions?
So yes, and yes. A couple of thoughts on that. So one is, everybody in this audience probably knows this, but one of the changes to health insurance in the ACA, not just health insurance through the exchange or not just in Medicaid, but for everybody's health insurance, is that there is a very large set of preventive services that are now free. You cannot be charged for them, and you do not have to meet your deductible before you access those preventive services. And what we find is there are just a lot of people who still don't know that. It's true for Medicare, it's true for your commercial insurance, your job-based insurance, Medicaid, exchange plans, all of those plans. This is a new basic rule from the Affordable Care Act. And what we are finding is that a lot of people just still don't know this. And so that is work on us and many of our partners and stakeholders to make sure that people are more informed about you can go get preventive services and you cannot be charged for them and you cannot have your deductible applied before you get those preventive services. So I think there really is an opportunity to do that. Now, not for all of those services, for many of them, it does involve going to your primary care doctor. And one of the things that we have seen is that many of the folks who are signing up for coverage through the exchange often never had health insurance. Either because they had a pre-existing condition and they couldn't get it, or just sort of their life experience is such where they've never had health insurance. And so, although it may seem sort of something to do when any of us might change jobs, we know, and get a different insurance, we know, oh, we have to pick a primary care provider, and then we should make an initial appointment in some reasonable amount of time, and at least have some relationship with that person. If you've never had health insurance, that is not as obvious to you. And so we really are, I think, moving into the next phase of the work around ACA implementation, now that those 20 million people have gained coverage, to translating the coverage to healthcare, to actually getting people connected. And so we have work to do, even just very basic things, helping people figure out, well, how do I choose a primary care doctor? Because it's not easy necessarily to go online and there's a million doctors and what's the name of my plan again? And the networks may be different for each. How do we provide better information for people and actually support them? We're looking at there's some models I know actually happening in Region 9 about folks who help people sign up for insurance, thinking about throughout the rest of the course of the year, how do they actually now provide people with information about, well, have you chosen a primary care doctor? Can I support you in that? Have you made an appointment? Do you know how to make an appointment? What can we do for that? Do you have transportation to get to that appointment? So I think we have work to do translating the new coverage into access to health care. And particularly so that people can focus on getting primary care and preventive services. And then on the issue of, you mentioned of sort of providers and health plans working together, I actually do think this is an incredibly important issue around care coordination. And I mentioned one of the priorities of Health and Human Services is what we call delivery system reform, and it has a couple of components to it. And one of them related to improving quality, sort of writ large, is this very issue of care coordination. And how do we think about all of the pieces of the healthcare system working together in a much more integrated way than they historically have? And so yes, I think getting those pieces to work together is, it's important for improving quality, but it's also important for working on the issue of cost. Sure.
As I think one of the few doctors in California that actually treats Medicaid patients, one of the things I've noticed is there's a push to move these patients into HMOs. And many times they're not aware that they've been pushed into an HMO until they try to come back and see you. And now, even in Medicaid, there are now networks. Obviously, a lot of that stems from the financial problems that California has as a state. And reimbursement for providers is 47th in the country. So you have states like Louisiana and Mississippi and such that get up to 60 cents per.
Right. The amount the federal government pays in Medicaid programs varies by state based on a series of calculations that involve poverty and other things.
How do we get that recalculated? Or how do we get to the point where we because I understand it was calculated many decades ago when California was robust and those states were not doing so well. Now, but in those years, California's had some lean times, and I'm wondering how do they recalculate that federal contribution to the state? Or how do we lobby for something?
So I'm going to wear two different hats for that. So first I'll wear my HHS hat, which is, to your point, it actually is a formula. So there are data points that go into that formula that determines the FMAP percentage. It's called the FMAP, the Federal Medicaid Assistance Percentage, for the Medicaid program. Because we talked earlier in the earlier session about Medicare, which is fully federally funded. The Medicaid program, which serves low-income people up to 138% of poverty, is a shared program between the state and the federal government. So each state's program has a foundation of basics that is set by the federal government, but then states have the ability to tailor to a degree the program that makes sense for their state and their population and their healthcare system that they are serving. And the amount that the federal government pays for the cost of that program varies by state based on this formula, is primarily driven by different poverty metrics. And so that has been set in standard for many years. I don't actually know the last time that that was sort of set and done, but it's been what it is in California is at a 50% FMAP. So the federal government pays 50% of the cost and the state pays that. So sort of that is set. Now let me take off my HHS hat and I'll put on my sort of personal Melissa Stafford Jones hat, whose career has almost been entirely in working on Medicaid and Medi-Cal issues and insured. Yeah, I'm a native Californian, and almost all of my work has been sort of in this space of Medicaid and Medi-Cal. And the challenge is that it does require statutory change. So it has to go through Congress in order to change the FMAP percentage or to change the formula. And because, at least in the current budget, right, it's sort of a fixed amount of money that goes to the Medicaid program. If one state gets a higher FMAP and gets more federal money, that likely means another state is going to get less. And that is a very difficult conversation in Congress. So as my personal sort of view as to why it is such a hard conversation to have to change that.
So, continuing on the cost of healthcare. So, I come from the NHS originally. So, and in a global capacity, very conscious of pricing policies outside of the US and within the US. And I have to say, as an American but a transplant, I still don't understand why the power of that federal dollar does not get reflected in the cost to the system for pharmaceuticals, for diagnostics, for you name it, when you put it in comparison with other G8 countries.
Yeah, so I think that in this delivery system reform priority that I mentioned that HHS has, it has three components. I mentioned the first one related to quality of care. The second is better spending, which is really thinking about the value of healthcare dollar, and in particular the issue of incentives and how incentives work. This came up in the prior panel. And the third has to do with the focus on better health. So really focusing on outcomes and health status and how our work as a health system in our country is actually advancing health. So let me focus for a minute on the payment sort of incentives piece and on that payment reform aspect, which I think is in part what you are getting to. So I think that we have a combination, as been alluded to in our healthcare system, a combination of fee-for-service, where you're paid for sort of an individual service or an individual drug, whatever it is, right? And then we have what we've also, been moving more toward, and I think we're seeing HHS signal that it's moving even more toward value-based payments or outcomes-based payment, where you're actually focusing on what is the result of that care delivered, how might we pay for that in some sort of a bundle. It could be a bundle for, currently there's a new program that started just today in a little over 60 markets in the country related to Medicare joint replacement and paying a bundled payment for that. So the hospital and the nursing home and the home health don't all get individually paid anymore in that demonstration. It's going to be one payment, and those groups of providers have to figure out amongst themselves how they're going to share that funding, with all of the goal of getting the highest quality of care you can for that joint replacement service and care. So I think you see examples like that where we are thinking about how do you differently align the incentives of payment to get toward the goal of higher quality, better outcomes, more patient-centered care. And we're doing that now in a variety of ways. So in the Medicare program, Secretary Burwell has set a set of goals around having more payments move out of fee-for-service and into these what are sometimes called alternative payment methodologies, which is sort of more of these outcomes-based type payments. And then even for the remaining fee-for-service payments, that they have some sort of a quality or value component to them. So even if you're going to be paid for doing an individual service, part of the amount of your payment will be dependent on the actual quality of care provided. And we've actually achieved the goal of the percentages she had set, which is moving the bar pretty far along already, but that work is continuing to do that. And I think within Medicaid, for example, you see that increasingly in the managed care context about how do we think about paying for the care overall for those patients. And then a lot of this is happening right now through demonstration projects, through the Center for Medicare and Medicaid Services, and really focusing on how do we test different models of payment that actually get to these incentive issues, align it, and then the things that work, how do we scale them up? So there are two things so far that have been found that the actuaries within the Center for Medicare and Medicaid Services have certified as really improving quality and cost and being worthwhile. One of those has to do with an accountable care organization, or an ACO, that you hear about. There's a lot of different kinds of ACOs, but there's one particular one that we have studied in Medicare through the Center for Medicare and Medicaid Innovation that has been shown to be very effective at reducing costs and improving quality. So looking at how to scale that up now in Medicare, and you may have seen an announcement just last week actually from Secretary Werlo about a second program that CMS is looking at doing that for, which is actually gets to the heart of your question around prevention and chronic care, which has to do with a program of the YMCA actually related to diabetes prevention. And looking at things like nutrition and physical activity and some of the underlying costs of people who are pre-diabetic, actually preventing them from getting diabetes. And that is now, after a number of sort of research projects around that, really being shown to be both cost and quality effective in improving health status. And so now CMS is going to be looking at, in the Medicare program, how do we scale that program up and make that part of the Medicare program and the Medicare benefits. So I think there is a lot of work happening on sort of, I didn't even mention all of it, there's really great work actually happening around cardiovascular health and how you do payment related to reducing risk for heart attack and stroke. So not just looking at, do we just lower blood pressure, do we just lower cholesterol, but as a package, all of the things that relate to reducing heart attack and stroke. How do we pay for reducing the risk of patients in terms of a physician's complete patient population? So all of these are about better aligning the payment incentives with the goals we want for our healthcare system, which is higher quality care and better health status. So we're doing it right now, I think, in a lot of pieces. And as I think that things emerge that really work, our intent is to try to scale those more tightly.
I wanted to ask, if you can't control or negotiate drug prices, and you don't have insurance rate regulation, then how can you really effectively control costs?
So a couple of thoughts on that. One is, you may know the President's budget proposal last year for FY 2016 and this year for FY 2017 does in fact propose to give the Secretary the authority to negotiate prices for certain kinds of drugs within the Medicare program. So that is something that we think would be beneficial to working on this issue, and something that we are putting forward and trying to make happen, because we agree that that would be another tool, not the only tool, but an important tool in terms of looking at that. And we do think there are other tools in terms of looking at this issue of balancing access to prescription drugs with the issues of innovation that were talked about in the prior panel. How do we keep that innovation going, supporting that, and making sure that drugs are advancing quality care? And so there are a few things happening on that. One is this proposal to allow the Secretary to negotiate. Another, along the lines you just mentioned, is we recently announced a proposal for a demonstration project in Medicare Part B, which is Medicare Part B has the drugs that have to do in hospital outpatient setting and doctor's offices, and actually looking at a series of 6 models that would test better ways to align how the payment happens for those drugs to actually advance quality, and think about how we do that so we actually get better outcomes and higher quality at a lower cost. And so I think we are looking at the different ways in which we can do that. Another is there is something called the Medicare drug spending dashboard, if you haven't ever looked at that, which actually provides tremendous transparency about what Medicare is paying for drugs, how much of those drugs are being prescribed, what the total cost is to the Medicare program. We do think that that kind of transparency is actually a really important part of the picture to looking at cost. So I think there are tools that we have and tools that we are utilizing to work on those issues. I think that the levers of working on cost, and I think we do think we have made some progress on cost. So for 2014, the total healthcare cost growth was around 5.3%, which compares to over the last 30 years, the average was around 9%. So I think we are actually seeing more moderate cost growth than we have seen in the last couple of decades. And the per capita spending growth was about 4.3%. And given some of the double-digit increases we've historically seen, particularly in the individual, insurance market compared to, say, what we saw in the marketplace, which is about 6.3%, we think we are making some progress on cost growth in terms of at least moderating it. Obviously, it's still going up. I'm the first to say it's still going up, but it's going up at a lower rate than what we had seen. So I think we have, my sort of assessment that would be progress. Keep your sleeves rolled up. We have a lot more work to do. I think some of that work, though, is this delivery system reform work, because in part, the cost of insurance reflects a number of different components, but one of the key components that it reflects is the underlying cost of care that is being delivered. And so we have got to continue this work on looking at what are the underlying costs of care. How do we have better quality? Better quality does not necessarily mean more expensive. There have been a number of studies that actually show better quality of care is actually lower cost. So there are places where we can get better quality at lower cost. We've got to do this work on financial incentives and really thinking about how do we spend our healthcare dollars more wisely? How do we focus the dollars we spend on quality? How do we focus them on outcomes? How do we align all of the parts of the system, to your question about coordination, to be rowing together in that direction and not thinking about it from a piecemeal standpoint? And then I think the other part on cost, I mentioned this a little earlier, I really think we have to continue to think about it in the sort of traditional medical care, healthcare setting of health insurance and hospitals and doctors. It's incredibly important, pharmaceuticals. I think simultaneously, though, it's very important that we do the work on thinking about the underlying issues. And maybe this is because I'm a public health person by training. What are the underlying issues that drive health? So, whether you live, whether you have a home and housing, and if that is safe housing, really impacts your health. I mean, I'm sure many of you have seen the data. Zip code is the best predictor of health status. So whether you have a job at a decent wage, access to healthy food, whether you have safe places to be sort of physically active, and you are physically active and that's part of your family and community and sort of individual life, these are all really important things that ultimately drive health and long-term will have an HHS actually that was created as part of the Affordable Care Act. So they are actually the ones that regulate the medical loss ratio for the ACA plans. So that's where that's happening. And I'll be honest, I'm not familiar enough with the standards to know where maybe what you would consider to be some of those gray areas of what plans are charged, where it falls in. But there is a regulatory framework for that, so that's something that we can certainly look at and provide you a little bit more. Then, you're right, for nonprofit hospitals in California, there are state standards, the SB 697 standards, and federal standards related to nonprofit status and the community benefit that they provide. And hospitals have to sort of demonstrate the community benefit and account for that. And there is wide variation in terms of what they are allowed to put in for the state law and the federal law. That is something that you're probably aware that Congress has been looking at actually for several years, particularly in the Senate, looking at sort of nonprofit hospital status and what defines community benefits. So I still think that's an active conversation, but the calculations of those are done in sort of separate ways for providers, for hospitals versus the health.
I'd like to leave because we're running out of time, for a couple of questions, and then you can have further questions during the Q&A session. So we don't have a wireless mic, so you have to go to the mic there. Yeah.
Is that okay? I don't know if this is on. Can everybody hear me? Okay. Because I sounded. Thank you so much for this wonderful discussion, and welcome back home, Ms. Melissa Stafford-Jones. I wanted to follow up on some of the comments that Dr. Paul Sunk had mentioned about Affordable Care Act ushering in consolidation, whether it comes to the insurance companies that are buying the smaller insurance companies, or the pharmaceutical industry becoming more consolidated, and now the hospital organization, HCA, is now becoming bigger and bigger. It just reminds me of, again, the 2008-2009 too big to fail experience that the United States went through. Are we seeing another set of bubble in healthcare where now the government cannot negotiate fairly with these big organizations because they're too big to fail? And most physicians are being either retired or being hired by these big organizations because they just cannot bear the burden of the administrative costs and the other requirements of Affordable Care Act, or they get penalized financially.
Yeah. So a couple of thoughts around that. On the last issue of physicians, one of the things we have certainly seen, and there's a physician survey that happens, I think it's every 2 years. The most recent one was done in 2014. Physicians across the country, all 50 states, I think the last one maybe 20,000 or so physicians participated in, asking basic questions around sort of their practice and that sort of thing. And we have seen definitely since 2008, so even pre-ACA, an ongoing movement from sort of individual solo practice or very small group, 2s and 3s, into larger group practices, or the states that allow employment by hospitals or other organizations. So I definitely think that was happening pre-ACA, and it's continuing post-ACA. And I think part of that is related to, the work and the focus on coordination of care, bringing all the parts of the system together. To your point, there are some infrastructure requirements these days in sort of the delivery of care that might be hard to do for an individual and solo physician to take on, the electronic health records or other things. So I think that that's a trend we've seen for a while now, and it seems to be continuing. I think with respect to consolidation and other parts, as I mentioned, there really are these sort of two separate parts of the federal government that work on that. So from sort of a what is legal in the marketplace point of view, that happens outside of HHS. It really happens in the Department of Justice or the FTC, depending on what part of the industry that we're talking about. And so that lens, it is obviously a really important lens, and those issues have to be looked at, but they're not looked at within the HHS context. So that's why I say HHS looks at it particularly from an access point of view, from a quality point of view, from is there vibrant competition in the exchange in terms of the insurer point of view, and that is something that we are continually monitoring. As I mentioned, so far, at least within the exchange context, we are continuing to see competition amongst plans for most consumers, where they do have a choice of at least 3 plans.
We have another question.
Well, good afternoon. My name is Brent Colton. I'm from UC Berkeley, and thank you all for convening this. I think it's a very important topic. And this question is for Melissa. Given your background from your experience in the Association of the California Public Hospitals, and Medicare being such a large payer, my question is with the dual eligibles, where they have both Medicare and Medicaid, where would you like to see, I guess, Medicare moving towards? They right now reimburse for healthcare services, but then we know the social determinants of health are very important, and particularly with mental illness, with the dual eligibles. So is through your innovation center or otherwise, are they doing initiatives that are not solely focused on the healthcare delivery? You touched on the YMCA initiative. I thought that was very innovative, but also for mental health, because I know those patients can be the most expensive for the Medicare and Medicaid program.
No, it's a great question, and one that definitely speaks to my mission and purpose in my work, so I really appreciate it. So a couple things. So one, with the dual eligibles, as you say, I mean, this is an incredibly fragile population, both elderly and very low income. And they because of the way we construct our care and the services that Medicare provides versus Medicaid provides, those folks often have 2 plans, and can be even intentionally in 2 separate managed care plans if they're in both Medicare Advantage and in Medi-Cal, like here in California, and it can be challenging. And so there actually are a series that are about how do you integrate care for the dual eligibles and try to create a combined sort of single point of focus for the care, where you're actually sort of combining the Medicare and Medicaid benefits and services and putting it into one for these people. At least on the outside, right? The back office function, so to speak, there's still, some separation, but from a consumer point of view, that it is really coordinated and consolidated. And California actually does have one of those demonstration programs right now for the dual eligibles, and so they are looking at that. And obviously one of the really big issues is long-term care, which is of course paid for through Medicaid and not Medicare, and that's one of the real areas in terms of looking at innovation and possibilities for better coordinating care related to long-term care, although not limited to that. So I think we still have more to learn and see how these demonstrations work. Here in California, one of the, and this is true in all the demonstration, patients can opt out. They're not required to be in it. And in California, in some counties that have pursued it's not everywhere in California, it's only in select counties that chose to do it and were considered prepared enough to do this, because it is a very fragile, complex population. You have to have the right systems in place to do that work. We've seen a pretty high opt-out rate actually in some places. So There's still time left in that demonstration project, so we'll have to sort of see where that goes. But I think it is an important population to think about coordination of care, and there are these demonstrations. I think we need to let them play out and then sort of see how that goes. But I have had people say to me, for example, for one of the dual eligible demonstrations, a medical group leader shared with me that the most important thing they've done, this was in Southern California for several of their patients, was actually buy them air conditioners. So, you know, that's what was important for thinking about maintaining this person's health in terms of what they could do for them. Then on the issue of just in general, social determinants of health, there's two things that I would point you to. One that's national, one that's California. So the national one is earlier this year, CMS released a new demonstration project called Accountable Health Communities, AHCs. Have you heard of this at all?
I think in Oregon, is that?
Well, this is new, but yes, Oregon
yeah.
through a Medicaid demonstration has actually done something a little bit similar to this. But the Accountable Health Communities, it's a demonstration project. And what it's doing is it's specifically inviting organizations to come together. There has to be a bridge, sort of a hub organization, but to come together with many other healthcare organizations for Medicaid and Medicare beneficiaries in their geographic area, however they end up defining that, and looking actually at those underlying social determinants of health and paying for services that would help address dealing with those as a coordinated group together. So looking, for example, potentially at housing or job training or other things that are connected to Medicare and Medicaid and the beneficiaries' needs and their health status, and thinking about how would you pay for those kind of support services collectively, working together across organizations in a community. I think this is an incredibly important demonstration. It's not huge. I think it's about $150 million, so they'll be funded across the country, but I think it's one to watch. I think it's very important because it is a signal, I think, from Medicare and Medicaid, from HHS essentially, that we are looking at those issues and how they impact ultimately health status and health spending and quality of care and the results that we all get in terms of people's overall health. So I think we share that view and are looking at demonstrations to do that. Here in California, there's also, so the Medicaid program allows states to try to innovate or do different things through waivers. And California recently negotiated a waiver with the federal government, with CMS and HHS, for a new Medicaid waiver. And one component in it is something called whole person care. And that is also where groups of organizations are going to come together at the county level. And they have to submit proposals to the state, as I understand it, and then the state will select a number of them. But that is actually about looking truly at sort of exactly what it's called, whole person care, and how do you bring together organizations that look at all the needs of an individual, getting much more, I think, to patient-centered care, right? Really, you know, we're not, I was having a conversation yesterday with a colleague from HUD, Housing and Urban Development. You know, people are one person. It's not that the left arm belongs with HUD and their right foot belongs with HHS and their left foot with the Department of Labor for their job training. I mean, that doesn't make any sense, right? I mean, all the pieces have to come together for an individual who, you know, may be in sort of a vulnerable health or life situation. And this whole person care model is going to fund demonstration projects specifically in California that brings groups together to try to say, for our population that we're targeting, and they can sort of target particular groups or populations with different chronic conditions, what is the array of services we need to bring together in a new and innovative way that will really focus in a patient-centered way on that? And then let's see what happens in terms of what the outcomes are for that patient population. So that's just getting up and going in California. The demonstration hasn't, they haven't even selected which counties will be doing that, but that work is in progress. So that might be something to follow if this is an issue you're interested in.
Yeah, those are all very encouraging.
Is anybody, there's time for just one quick question now? Okay. Then I'm going to conclude that you can ask questions during the next session.